you can see my face alone. That's good.
No, I can see your collar and your face and this glowing light of knowledge and
Yes,
brilliance
yes.
shining on you.
Yeah.
Halo behind
Okay.
the head of this
Halo.
I think
particular.
halo behind the
Halo
head.
also is there.
Akash, let me know.
Hello. So, sir, we are live now. Over to you, sir.
Okay. Yes. Shall I start, Rashika?
Yes, sir.
Hello? Shall I start?
Yes, sir. We are
Good
online.
evening. Good evening on behalf of the Tamil Nadu Ophthalmic Association as the president of the TNOA. I have great pleasure in welcoming you all for this 10th ARC TNOA ARC PG Catalyst Masterclass series, which is being powered by the Milmet. I'm very thankful to Milmet for powering all these webinars, which has been a huge hit among not only among the postgraduates and the residents, but also among the practicing ophthalmologists in general. So, friends, TNOA has been very active in the what you call the academic sphere for the past almost 8 months now since I took over in September 2021. And we've been having a series of activities. And the first of this kind, it's the first Friday of first Saturday of every month. We have the Walk the Talk series, which has become a huge hit because it's really inspiring and motivating. Last week, we had the wonderful interview with Dr. T.S. Surendran, our guru and vice chairman of Shankar Netralaya, who gave the story of not only himself, but also Shankar Netralaya, which inspired and rejuvenated and motivated all of us. And of course, the TNOA ARC PG Masterclass has been a huge hit again, a grand success. Until now, you will not believe it, more than 25,000 ophthalmologists have watched this masterclass series on the YouTube and the Facebook and consecutively and successively. And it's been a very huge appreciation from all over. And of course, the TNOA Connect series, which is on the last Sunday of every month, wherein we connect all the major institutions in Tamil Nadu. As you know, Tamil Nadu is the mecca of ophthalmic institutions across India. And we connected, and every subspecialty of ophthalmology has been covered in this Connect series. And we have also had, the last month, we had the Connect series with I don't know whom. Rajshekar, remember with whom we had the Connect series last month?
You know, you connect last month. I'll just check up the one.
No problem. We had, so every last Sunday of every month, we are having the Connect series. And this, on day after tomorrow, we are having the Connect series on ophthalmic trauma with Joseph Eye Hospital, Trichy, and which has become the gold standard, as you know, as far as ophthalmic teaching in Tamil Nadu is concerned. And the Gurukulam, which is again a very important program, which we initiated in the month of April. All the 4 Sundays of April, we had 19 faculty discussing about 26 topics from 8 a.m. in the morning to 1 p.m. in the afternoon. And it was a huge success. I would say thanks to Dr. D. Chandrasekhar and VRV of Coimbatore, who have been spearheading this Gurukulam, which has been a very, very well appreciated by all the ophthalmologists and residents across the country as well. So today we have none other than Dr. Naveen Jayakumar, who's the master here. And you know, Naveen does not require any introduction. Naveen is a very close friend of mine, my classmate in Madras Medical College, and truly an outstanding guy. And he is a master of not only neuro-ophthalmology, the master of quiz. You can see he's a master of everything. I would say Naveen Jayakumar. And we had the wonderful opportunity of working together as well. And Naveen, it's really a pleasure to have you on board for this neuro-ophthalmology masterclass. And of course, the other faculty also, Dr. Ambika and Dr. Mahesh, who doesn't require any introduction. I'll be failing in my duty if you don't recognize the efforts of our chairman ARC, Dr. Rajshekar, who's been actually spearheading the complete academic, the ARC PG masterclass. And Dr. Rajshekar, hats off to you because you've been completely there and you've been behind this and showing this is really a fantastic, and your inputs on this masterclass has been really tremendous and very remarkable as well. And of course, Dr. Manoj Vasudevan, who has worked tirelessly for the past few months to make this masterclass a very huge success. A couple of weeks back, we had the masterclass on refractive surgery by Dr. Anand Parsadi. Again, effort which has been taken by Dr. Manoj Vastevan to make this masterclass a very huge success as well. With these few words, I hand over the proceedings to the moderator for the ARC masterclass, our chairman ARC, Dr. Raj Shekhar.
Welcome to all. And this is a grand day again for the brand of TNOA ARC Masterclass. Today, with the encouragement of our President, Dr. Mohan Rajan, the office bearers, and all well-wishers of this TNOA academic series, we have the who's who of neuro-ophthalmology. In fact, the who's who of neuro-ophthalmology, we have Dr. Naveen Jayakumar, Dr. Ambika, and Dr. Mahesh to speak to us on the other who's who of neuro-ophthalmology topic. I consider these topics more popular than the speakers themselves. They should excuse me for that, because the feedback we are getting from the students and the interest it has evoked amongst the student community is phenomenal. And the topics which are going to be discussed today, Dr. Ambika will speak about sudden vision loss. Dr. Mahesh will speak about pupil, and Dr. Naveen will speak about clinical features of diploma, clinical aspects of diplopia management. So in that way, we will be going on, and the house rules are, once the speakers are completing, the students who are attending and the young ophthalmologists who are watching us on all the platforms can type in their queries into the chat box, and I and my co-moderator, Dr. Manoj, will be voicing them and getting on with the discussion. And sure, we have a veritable feast on neuro-ophthalmology. And may I invite Dr. Naveen Jayakumar, the master trainer, the course master of today's program, to just introduce us to the speakers and the topic. Please, sir. Dr. Naveen, sir.
And thank you, Naveen, because he is logged in from all the way from Houston. And that shows his commitment and love and affection for all of us. Thank you very much, Naveen.
Thank you, Mohan. Thank you, Mohan. And thank you, Dr. Rajshekhar and Dr. Manoj, for inviting us to be part of this very special masterclass. I think I really didn't have very much to do at all in terms of managing anything here, not just because of Mahesh and Rajshekhar and Mohan, but also because I have two wonderful people who've had my back for a very, very long time and whom I can trust completely to do a wonderful job with these topics. I'm talking about my two esteemed colleagues here, Mahesh from Arvind Eye Hospital, and of course my student and head of the department of neuro-ophthalmology in Shankar Nethralaya, Dr. Ambika, whom I'm very proud to have here with me as well. We'll start off today's proceedings as Dr. Rajshekhar and Mohan mentioned that I think these three topics are always will be a success in any postgraduate meeting, possibly because not only is it very common, but it also causes the most amount of confusion in terms of approach and management, etc. So I think it's important to touch on these topics, which I think you will see a lot of in your careers. Let's start off with Dr. Ambika today. We'll start with the afferent and then move on to the efferent system, as is the convention. And so I'll invite Dr. Ambika to speak about sudden vision loss, a neuro-ophthalmology perspective.
Thank you so much, the organizers and Dr. Naveen Jayakumar, for having us here. Is my screen visible?
Yes.
Yes, yes.
Very much.
So today I'm going to talk on approach to sudden vision loss as from the neuro-ophthalmology perspectives. So we all are aware as ophthalmologists that sudden vision loss is something, an emergency, which we deal in our day-to-day practice. And we have umpteen number of causes which are producing that in ophthalmology, starting from giant retinal tear causing a retinal detachment to retinal hemorrhages, central retinal artery occlusion, central retinal vein occlusion, and post-traumatic sequelae. But coming to neuro-ophthalmology, there are some causes which will result in sudden visual loss, which invariably will be beginning with the optic nerve, which may be having a normal optic nerve head on appearance or a dyschedema. And intracranial causes can also result in acute sudden vision loss, which has to be differentiated from an afferent pathology. So cortical blindness can also linger in this group of sudden diminution of vision. When you see a patient with sudden drop in vision, always I would say key of any neuro-ophthalmic examination is a detailed history taking. So any patient with a sudden drop in vision, if there is an associated pain or no pain, presence of squint, double vision, headache, surgery history, any malignancy, any radiotherapy, all these histories are very important when you deal a sudden vision loss in neuro-ophthalmologist. And most importantly, if it is going to be a monocular vision loss, please confirm whether the vision onset is clear. Because many a times we will end up having patients coming with sudden onset of vision loss and you see a pale disc inside. So probably the patient could have noticed that the vision drop accidentally, because that makes a lot of difference in your evaluation and management. So these are the plethora of the disc appearance which can present with an optic pathway dysfunction and a sudden vision loss, starting from a normal appearing optic nerve head to disc edemas of various shades. And as I told, it can even present with a pale disc. So other causes which can linger in a sudden vision loss are unexplained vision loss and functional vision loss. So be careful in deciphering these two etiologies when you deal with an acute optic nerve dysfunction with a normal optic nerve head appearance. So because of the atypical presentations, we need a clinical expertise, do a comprehensive evaluation, differentiate these optic neuropathy versus a retinopathy, because this unexplained vision loss is definitely going to give us some problems because they have a lot of medical legal pitfalls. So as I mentioned, history taking is the key. Any patient with an optic nerve dysfunction would present with sudden darkness. How do they come up with the history? It may be the colors can be less vibrant, a bleached appearance. Sometimes they can say about the visual field pattern loss, an altitudinal, a sectoral, a hemifield loss. And patients can also present with few transient obscuration of vision, which could ranging from 3 seconds to 30 minutes. So if the loss pattern we will be also knowing the type of the optic neuropathy we deal. So any acute vision loss where you're going to brand it as an optic neuropathy, watch for the tempo of the visual loss, what we call. When you have an acute painless vision loss, which recovers to a certain extent and reaches a plateau without having a very great improvement, is nothing than a vascular cause and ischemic event. If there is an acute painful or painless vision loss, which improves, the vision recovers to a certain extent, 2 weeks plus, if it is going to improve, we are dealing the tempo of an optic neuritis, rather inflammatory optic neuropathy. If it is going to be a gradual progressive drop in vision, which can escalate sometimes with a sudden worsening of further vision drop, that is invariably a compressive onset. So based on the tempo of the vision loss, you can predict what type of optic neuropathy we are dealing with. And next comes the macular presenting symptoms. Sometimes the patient may have an associated macular problem along with an optic nerve. Those patients can complain of metamorphopsias, distortion. There'll be a transient acquired hyperopia and blurriness. Rule out a history of trauma, any systemic diseases, and age to rule out the other causes of a macular problem. Thanks to the pandemic, now with any patient who is stepping into neuro-ophthalmology, we ask this history of being COVID positivity, grade the severity of illness and the treatment which are being given to the patient. And also nothing, even a COVID vaccination history, particularly the AstraZeneca variety, we are seeing a lot of COVID associated or COVID vaccine related neuro-ophthalmic complaints presenting with an acute vision loss. So remember, optic neuritis, NION, a cranial nerve palsy, a central retinal artery occlusion, and a cerebral venous sinus thrombosis is not unusual, what we have seen post-COVID after the pandemic. So these can also present with a sudden vision loss to us. So In the history, if you see a patient walking in with a sudden vision loss and you see a disc edema, so first of all, you confirm what we are seeing, is it a true disc edema or a pseudo edema? If we are seeing a true disc edema, differentiate if it is an optic neuropathy or a papilledema, because optic neuropathy can be unilateral or bilateral, and papilledema is invariably bilateral. And when you see the optic nerve function impairment, it is most common when you brand it as an optic neuropathy, because papilledema in the early stages, the vision and all the parameters of optic nerve functions are well preserved. So if you have an acute vision loss, remember, before branding it as a papilledema, you have to be very careful, because papilledema does not cause a sudden vision loss in the early stages. So as I mentioned, if there is an acute vision loss, which is painful, remember, it could be an inflammatory cause. If it is painless, it could be a vascular cause. And if it is a painful, some patients, what we brand as an atypical optic neuritis, which is not very unusual for this group of audience, we also have them presenting as painless. So that's a different genre, which I think you have to get more understanding about the disease per se. And if it's a gradual painless vision loss, most of the times rule out a compressive etiology. And if it is a papilledema and presenting with a sudden vision loss, it should be only in the late stages, where we see in case of a fulminant IIH or a cerebral venous sinus thrombosis. There, yes, it is possible to have a sudden visual loss, which could be asymmetric or even a monocular loss in a setting of papilledema. So these are the various type of infectious and inflammatory optic neuropathies, which I mentioned that they can come with an acute vision loss. Painful, if it is going to be a monocular or binocular cause. If it is only involving the optic nerve head, it's optic neuritis. If it is involving the optic disc as well as the retinal inflammation with exudates and a macular star, it's a neuroretinitis. It's important to differentiate from an optic neuritis, because neuroretinitis usually is tagged behind an infectious and a para-infectious cause. Very, very unlikely you would see a neuroretinitis as a harbinger for a demyelinating spectrum of disease, because it is optic neuritis, which is most commonly. In fact, we have seen MS patients presenting even with posterior uveitis. So uveitis is not unusual in a setting of optic neuritis and multiple sclerosis. So this is the classical hallmark of optic nerve head swelling, a painful sudden visual loss, central scotoma on visual field, a hyperintense T2 signal on the axial cuts of an optic nerve on MRI. This is the classical optic neuritis. So if you see any patient walking in with this, watch out. You're going to deal with definitely a serious disorder in the later stages. If it is a vascular cause, as I had mentioned, it could be an arthritic or non-arthritic ischemic optic neuropathy, a central retinal vein occlusion, diabetic papillopathies, and CCFs. Not that commonly we do see with an acute vision loss, but yes, it is possible. And this is the classical sectoral disc edema, which we see in a non-arthritic anterior ischemic optic neuropathy. Most common disorder of vascular occlusion with a sudden vision loss we do see in this group of patients is all these patients associated with vascular risk factors like diabetes, hypertension, and renal disorders, and post-COVID vaccinations. And if you have an hypercoagulable conditions, these all can precipitate, and even an obstructive sleep apnea is possible to incite an acute vision loss and cause an ischemic optic neuropathy. So when you want to evaluate, you want to rule out all these optic nerve dysfunctions, always do a stepwise approach. We have done a sufficient history taking. Now we are going into the examination. Once you make the diagnosis, then only you're going to be in the prompt line of management. So visual acuity, color vision, pupillary examination, anterior and posterior segment fundus evaluation, and then a visual fields. All these form the key of optic nerve function assessments. So do not miss any of these steps, which can make us miss a huge diagnosis behind. And all these electroretinogram, BEP, all these diagnostic procedures do have their role, but I think they also have a limited role when you play an acute vision loss. And if it is going to, and if you have an optic nerve function, always a must is a field examination. Even if the patient has a profound visual loss where you could not do a Humphrey visual field analysis, the gold standard confrontation test also will give you a clue on the type of the visual field or the scotoma. If it is, most of the neuro-ophthalmic conditions do present with a central visual field loss, unlike a very few ones which have a peripheral visual field loss. Amsler testing, ultrasound, fluorescent angiogram, all these things also have a role. But now OCT has taken a toll, and it is literally one of the indispensable tools in assessing the structural and prognostic changes of an optic neuropathy. So relative afferent pupillary defect in a monocular vision loss is the key of an optic nerve dysfunction. If a patient comes with a monocular sudden vision loss, always look for a relative afferent pupillary defect. But if it is going to be a higher retrochiasmal cause, you may not elicit a relative afferent pupillary disorder. If it is a binocular sudden vision loss, the pupils will not be reacting briskly. It will be a sluggish reaction of the pupil. So that also will give us the clue that how significant is the dysfunction of the optic nerve. As I mentioned, this is the optic nerve tube, which will give the average RNFL thickness and the ganglion cell macular cube pictures. I've just added for completion because in an acute setting, it may not be that possible to get this complete structural analysis. So as I mentioned, if you want to investigate an optic neuropathy, be it a normal appearing optic nerve head or an optic disc edema, always following a history taking, do all these key optic nerve function tests and do a blood pressure recording if you see a patient coming with a bilateral disc edema. Never forget to record the blood pressure when you see a bilateral disc edema. And then follows the blood evaluations, all these blood workups, customized depending on the type of the optic neuropathy, what you think of. If it is an autoimmune, ischemic, or an infective, depending on that, you can start the type of investigations, starting from the blood test. And neuroimaging, always MRI brain and orbit with a contrast is a choice, unlike CT, which has a very limited role in most of the neuro-ophthalmic disorders. So maybe if there are, if it's going to be an interactive, I kept this slide. I don't know whether it's possible. So this is a 52-year-old female who came to us, who had a normal vision in the right eye and left eye had a 612N6. And when I saw it was a posterior polar cataract, and this was the optic nerve head what I saw in the fundus. So I just wanted to ask the postgraduates, what's the next investigation of choice you would think of? Maybe a visual field. Yes, the fields are almost normal. So I feel this is not a true disc edema and this is a pseudoedema. So probably we see an unscathed blood vessels around it and all the margins are clear. This is a pseudo disc edema. So probably she did not realize she had a simple posterior polar cataract. On closing one eye, she got to know that the vision is less and it happened to be having an eye with a pseudoedema. So that's the reason which confirmed on an ultrasound where we could put this high gain reflexes on the B scan over A scan, which confirmed that it is an optic nerve head drusen. So we are going to go through few clinical scenarios. Organizers, please stop me if I'm exceeding my time anytime. So I have thought it'll be nice always to learn from others how they dealt with their cases. So I'm going to go on few cases which came with sudden vision loss in our department. So this is a 17-year-old girl who was brought to us with sudden vision loss during the peak summer, exactly something like this with the peak summer during the board examinations. Her parents brought her where she was branded as malingering by the local doctor. She had a bilateral visual loss with a completely normal fundus evaluation and an anterior segment examination. So she had hand movements, closed face, but the key was both the pupils were very sluggishly reacting to light. There was no relative afferent pupillary defect. And this is this particular investigation which gave us a mind-blowing change to the entire picture. She had a gross delayed latency as well as amplitudes in both the eyes, the EP, and this was the fundus examination, which was almost normal. So then we convinced the patient's father that it's a retrobulbar neuritis, what you're dealing with is an acute condition. So she needs immediate treatment. She got an MRI brain in orbit, following which we put her on IV steroids. by 2 weeks, she improved to 618 and 8. And these are the visual field defects where you could see a dense central scotomas in both the eyes, but still the color vision did not improve even after a month also when she improved to 6.9 and 6. So after this, she came 4 years later to us just to say that she's going for her higher studies to somewhere outside India. So that time she had 6.9 and 6, but she gave this history which literally took us all back. She gave us that sensation of loss of hand, unable to hold objects, and poor bladder control. Here, this is something very important in a patient who presented to us long back with retrobulbar neuritis in both eyes. So she had a persisting central field defect. So I repeated the MRI, and this is what you saw in the MRI. These are the classical Dawson's fingers, what we call, or periventricular hyperintense signals, which are enhancing, and this is classical multiple sclerosis. So a patient who came with an acute vision loss, 4 years later, developed MS. She was put on, all the zero markers were negative. She was put on interferon and maintenance drug, and she maintained 6.6 and 6. So this was an MS optic neuritis presenting as retrobulbar neuritis to us. So this is the second case which was referred as a RRMS, which is a relapsing remitting multiple sclerosis. From the MSSI Society, we keep getting patients like this for routine evaluation. So this young lady also came sometimes with a good vision when I saw her. She had some episodic mild vision drops in the past, but she had a good vision when I saw her. And as a part of our routine follow workup, we did an OCT and a repeated an antibody assessment where we picked up in our immunofluorescent assay, she was positive for this NMO antibody, which is aquaporin antibody. You remember she's been treated as RRMS. She's on interferon therapy. She had a report which was done elsewhere as an ELISA assessment, which was negative NMO antibody. So I cautioned the neurologist with this tag and I sent her back saying that this may not be an MS and I suspect an NMO spectrum for her. So maybe we can just pull her off interferon and watch her if she relapses with the events. As I suspected, 3 months later, she walked into our emergency when she was on interferon after a viral fever, a severe visual loss in both the eyes. She had sluggishly reacting pupil. And if you could see this visual fields, she had bilateral, dense inferior temporal defects. It is almost like an inferior temporal quadrantanopic defects on the visual fields. So this made me repeat the MRI. There was an increase in the white matter lesions in the corpus callosum and the posterior chiasm. If you could see in this coronal cut, you see the whole optic chiasm is thickened. This is called chiasmal neuritis, which is the classical finding of an NMO spectrum disorder. So what she had is an NMO spectrum disorder optic neuritis, and it was not MS. So immediately I told the patient to be off interferon, requested the neurologist to put her on intravenous steroids and start on a course of rituximab, because we need a higher suppression by now because it is not going to respond when the patient was already on a longer interferon therapy. Within a short while, she improved, started responding to the treatment. And this is the visual field, what we could see down the line. So rituximab was replaced as a maintenance therapy. We kept the patient on azathioprine and her vision and fields reversed to normal. So this was a patient which presented with NMO spectrum disorder and an acute chiasmal neuritis. So case 3 is a young lady who again walked in with a bilateral sudden drop in vision, where she was suspected as retrobulbar neuritis and she was referred for intravenous steroid therapy to us. So when I saw her, she had counting fingers 2 meters in one eye and she denied perception of light in other eye. But pupils were briskly reacting to light in both the eyes, which prompted me to think, if at all, is it really an optic nerve dysfunction? So I repeated the VEP, which was giving a very good waveforms, and that was a case of functional visual loss. So be careful that we end up seeing these type of patients also masked as retrobulbar neuritis. So do not overdiagnose retrobulbar neuritis when the patients are coming in with a sudden visual loss. So when you see a brisk pupil without an afferent pupillary defect, Even if you have a bilateral visual loss, as I mentioned, a sluggish pupil will give you a clue that we are not dealing with an optic nerve dysfunction along with a normal EEP. So this is a 65-year-old male who was brought by his son with a sudden vision loss. Again, his pupils are briskly reacting to light, but not more than perception of light we could elicit a vision in that guy. And he had dense cataract, and the son was saying that he has come here for cataract surgery. When I saw the fundus evaluation, fundus was normal. Fundus normal, dense cataract, pupils briskly reacting to light. Yes, of course, he had almost a near total cataract in one eye, and other eye was having a dense nuclear sclerosis. But when it is sudden vision loss, I started talking to him. I said that I made him walk from the slit lamp couch to the indirect. He was literally bumping into all the objects where the cataract is disproportionate to the vision loss. So which made me do a VEP. Again, there was a very mild delay in latency with so much of media opacity. We can't get a very good, great VEP waveforms. Still unable to explain the vision loss. I told the son, I think better we will get an MRI, rule out a cortical cause, then plan for a cataract surgery because I'm not very convinced his cataract is the reason for the visual loss. And we did the MRI, and this is what we picked. So this is a bilateral PCA infarct. The guy has an LXT. He already had a PCA infarct in one eye, and he was just going around with his other eye, and an acute PCA infarct in that side also made him going for a severe visual loss in both the eyes, and that's a cortical visual impairment secondary to a PCA infarct. And be careful before operating such cases for a cataract surgery. So this is a 47-year-old female. She was referred to us with a diagnosis of a thyroid eye disease or probably a keratoconcavenous fistula. She had painful diplopia. She responded to steroids earlier. Her thyroid profile was normal. She had a sudden drop in vision. Within 10 days, she had both the eyes, left eye more than the right eye. She had severe redness, diplopia, and restricted extraocular motility in both the eyes. When I checked, the vision in the right eye was down and left was more than the right eye. So extraocular movement is restricted, color vision abnormal, vision down. So this is her extraocular motility. You could see that grossly thickened lid with chemosis, congestion, extraocular motility. Almost she was behaving like a significant CCVS, CCF. And this was her disc appearance. So she had a significant disc edema in both the eyes, right eye more than the left eye. But see the visual fields, she had dense central field defects in both eyes. So now the diagnosis is out. There's a diffuse thickening of the extraocular muscles, both the sides. But interestingly, you can see it is not a tendon sparing type of thickness, which we classically see in a thyroid eye disease. This is diffusely, the whole muscles are thickened, and definitely there's an orbital apex crowding. The coronal cuts are showing a grossly bulky extraocular muscles, and there's a bilateral orbital apex compression, which is causing her a sudden vision loss in this sitting. So our differentials were all these conditions: an IOID, a myositis, a TED, or an IgG4 orbitopathy, which is causing an acute compressive optic neuropathy. So I asked for all these clearance opinions from an endocrinologist, rheumatologist. We put her on IV 1 gram steroids, but then I asked our plasty people, why don't we just try for a muscle biopsy also? Because she had already 2-3 episodes of this and she's been confused whether she's having a CCF. She was not having a classical CCF findings on an MRI. And yes, her anti-TPO was elevated, probably suspecting some thyroiditis or an autoimmune phenomenon. So when we did the muscle biopsy, we saw classical sarcoid granulomas. And what we were dealing was a compressive optic neuropathy secondary to an inflammatory myositis, which was granulomatous etiology. And that was a sarcoid-related myositis, which was causing an acute bilateral event, compressing the nerves and behaving like a thyroid eye disease versus a CCM. So this is the post-treatment photograph of the patient. Post-intravenous steroids and oral steroids, she recovered very well. Her vision improved and her extraocular motility and all the soft tissue signs also recovered very well. So this is a 28-year, this is during the pandemic, we saw this young man and very depressing history. This guy was actually from US. He was an engineer where he had a headache, transient visual loss, and tinnitus for 4 months. So when he was in US, he developed all these complaints and he had a sudden, rapidly progressive drop in vision over a period of 3 weeks. He had a recent weight gain. He developed COVID infection. He was in home quarantine in US. He was also vaccinated by Moderna vaccine, 2 shots during the stay in US. But the only thing is he had a headache, a transient visual loss, and a retrooral pain. And the local doctor in US, we could not trace his fundus photo, what was his presenting symptoms when he went to the doctor in US. There they said that there is some mastoid region fluid, probably a mastoiditis. Your CSF was negative for infections. Opening pressure was not available. He was diagnosed as malignant hypertension because he had a blood pressure of 160 on 130 as per the records what he carried to us. So he was treated as hypertensive, malignant hypertensive sequelae because he had a bilateral massive disc edema. And he was also treated with antibiotics for his mastoiditis. So he started working back because his headache settled. But in November, again, he started developing severe headache with binocular double vision, transient visual loss, and his vision started rapidly dropping. He was 20/200 and 20/100 in both the eyes at that time. At that time, his local doctor has referred him to a neurologist where his CSF opening pressure was 34 and he was started on aggressive anti-edema measures. By then, he has already lost most of his visual fields. You could see this is an Opto's photograph, what he was carrying, where you could see a gross papilledema in both the eyes. And he was treated as malignant hypertension. But in spite of having a blood pressure control, the disc edema did not come down and his visual parameters started declining. And that's when the other etiology started unfolding. So when we saw the patient in November, he almost had a 3/60 vision, 2/60 in both eyes, completely zeroed down color vision, bilateral sluggish pupils. So this was the fundus picture when we saw a resolving disc edema with a lot of macular exudation and almost like a massive disc which is trying to settle down at a washed out visual fields, even on a size 5 program on free visual fields. And this was the OCT RNFL average thickness, which was almost more than 200 plus. So we had a differentials. We have to rule out the other conditions like a papilledema secondary to a cerebral venous sinus thrombosis in view of his past history of infections. And we went ahead, repeated his MR venogram. He had an extensive superosagittal sinus, transverse sinus, and sigmoid sinus thrombosis. So then I asked the treating neurosurgeon to go ahead with the CVST management, but then that time they had a doubt. They said that there could be a possibility of a dural AV fistula, which is precipitating this entire extensive cortical venous reflex. So they also planned for a DSA, which also confirmed that he had many leptomeningeal dural AV fistulas, which they tried to coil them, and embolization was performed in the December. By then, because of his rapidly declining visual parameters, the neurosurgeon, after the embolization of dural AV fistula, he sent the patient back to us. And I did an optic nerve sheath fenestration in his left eye. And this was his RNFL range when we planned for an ONSF. This is the RNFL on pre-ONSF. You could see whether it was almost 230 to 270. And this is immediately 2 weeks later, the optic nerve sheath fenestration of both the eyes, RNFL significantly reduced, but his vision parameters did not greatly recover in both the eyes, and we are waiting for his subsequent follow-up. So this was a case of fulminant IIH with a severe papilledema with a dural AV malformation presenting with a acute vision loss in a young male. So you have to be very careful
Ambika,
when you're
sorry
dealing.
to interrupt. If you have any further cases, can we do it during the discussion?
So the case, yeah.
Yeah, after we finish. Yeah.
So Let me conclude saying that acute vision loss is an ophthalmic emergency. Neuro-ophthalmic causes can be life-threatening at times, so we have to do a detailed evaluation and a stepwise approach. Optic neuropathy can be picked up by the tempo of the vision loss. Always differentiate a maculopathy versus an optic neuropathy. And yes, Amsler testing, electrophysiological test, and neuroimaging all have their respective roles in pinning down the cause, but nothing like if you are having a difficulty in any neuro-ophthalmic practice, if you're not able to make a diagnosis, just go back and talk to your patient, because history taking is the key for any neuro-ophthalmic disorder. Thank you so much for the time. Thank you so much.
Thank you, Ambika.
Yeah.
Dr. Rajshekhar, if there are any
Yes,
questions,
sir.
we'll take
Yes,
a
sir.
couple
Yes, sir.
now,
Yes,
and
sir.
then
Wonderful
Yeah,
talk,
we'll take the
Ambika.
questions and we'll go through a panel discussion on the topic as we have discussed, and then we'll go to the next topic, sir.
yes, please.
Yamar, sir, any comments? And we'll start
No,
with
no,
the
I
question.
think it's are you able to hear me?
Yeah,
Yes,
yeah, yeah, yeah.
I'm in the airport lounge. It's really a wonderful talk, Ambika. I think it was a 360-degree coverage as far as optic
Yes.
neuropathy and other sudden visual loss is concerned, and neurological, and it is really fantastic. It is typically a very, very what you call good, I would say, master class, and none other than from the master, Dr. Ambika. It is really fantastic. And the only thing is, I just wanted to ask you one question, Ambika. Do you give any importance to the age at which they present? For example, younger age group, you think it's optic neuritis. Older age group, you think it's a ischemic optic neuropathy. So the age of the patient and the sex of the patient, does it matter in the clinical examination as well? You're muted.
Ambika, we can't hear you.
You have to unmute.
I think she's having a problem with her. Mahesh,
No,
would you
she's
like?
muted.
The other panelists can take up that question.
Yeah, Mahesh, would
Yes,
you
yes.
like to answer that about the age?
Am I audible?
Yes, sir.
Yes,
Mahesh.
you are.
Yeah, that age is a very important factor in determining whether what is a likely etiology. For example, younger age, we would think of certain things like optic neuritis or ischemic optic neuropathy. We would think more in terms of more age. So age, I would say, is definitely a very important factor determining what are the likely etiologies in these conditions.
Mohan,
Am I
you asked
audible
about sex. Yes, you are audible.
Yes, yes.
Go
Okay.
ahead, Ambika, tell me.
I can add one point, because
Yes.
I have stopped looking at age too much now, because we are having NAION also in younger individuals of late. We are seeing a lot of 20s and 30s walking in with a non-arthritic anterior ischemic optic neuropathy. Probably, I agree with Dr. Mahesh to a certain extent in optic neuritis, because classical optic neuritis do present with second to fourth decade. But anything less than 20 or more than 40s, we always be skeptical as an atypical optic neuritis. Number two, if it is going to be an ischemic optic neuropathy, which is a gray zone, you have to be very careful if you're having a patient 40 plus walking in with a swollen disc, where you're going to brand them with an ischemic optic neuropathy, because it is there where we have the atypical causes like autoimmune optic neuropathy, MOG optic neuritis, spectrum disorders. All of them do present with a painless and an acute vision loss. Although these patients do have vascular risk factors, because in India, I think more than 60 to 70% of them have diabetes. So diabetes is definitely going to sit in all these patients' history. If you're going to make a diagnosis of ischemic optic neuropathy, be very, very cautious in the age group between 40 to 50 plus. And I have giant cell arthritis presenting even at the age of 55. I have made a diagnosis of 55 giant cell arthritis, and I have made a diagnosis of retrobulbar neuritis in a 72-year-old male. So age to certain extent can help you in making the diagnosis, but definitely the history and the findings, if they are not more towards a neuritis in that particular age group, always keep an atypical optic neuritis in the background, where it can be of any etiology.
Thank you, Ambika.
Yeah.
Naveen.
Few more questions from my side. The students have keyed in. One question they're asking is, this course of optic neuritis, like sudden, then resolving, will it be the same in recurrent neuritis also? That is a question, madam. I
Okay.
think all
If it
panelists can
is
take that.
if it is going to be a recurrent optic neuritis, what type of recurrent optic neuritis? So is it going to be a Mog spectrum optic neuritis? Because now we have more understanding on these optic neuritis, which can be of Mog spectrum disorder, which could be a multiple sclerosis related disorder. It could be even a simple uveitic associated optic neuritis. So always differentiate the other causes of recurrent optic neuritis. And if you're going to have a classical demyelinating optic neuritis, if it is going to be an isolated idiopathic optic neuritis, not associated with any of this demyelinating spectrum, most of the time they respond. But down the line, when the recurrences are increasing and the treatment pattern is also going to escalate, there may be events where in an NMO spectrum disorder, we may not get a classical recovery pattern. But MOG, most of the times, do respond to the treatment and depends on how soon and how severe you're giving the immunosuppression. That's what I said in that NMO spectrum disorder patient. She has already received a lot of interferons. So that immune system is not going to respond only to IV methylprednisolone. We need an iron hand of immunosuppression. That's the reason why we chose for a rituximab. That recurrent neuritis will definitely respond if we give a higher immunosuppression. So the pattern can change depending on the seromarker which is sitting behind the recurrence.
We'll take one
In
more
fact,
question,
the same
Rajshekar, before we
person,
move on to the next topic.
Yeah, sir. In fact, the same person has asked another question. He's asking, like, shall we start IV methylprednisolone with just a clinical judgment, or we need to clinch with some investigation? That is another question.
Optic neuritis is a clinical diagnosis. You're going to treat the patient with the clinical diagnosis, and MRI is just to confirm the prognosis of the patient. And MRI is going to aid the pattern and the behavior of the optic neuritis. But be sure that what we make a diagnosis is definitely an optic neuritis before starting an IV steroid. And please take home message, postgraduates, do not start any acute optic neuritis only with oral steroids. Better don't treat them. They will have a natural recovery by 2 to 3 weeks. And even if they come with a recurrence, we can probably get the next level of treatment. Isolated oral steroids for a classical acute optic neuritis is better to be avoided.
One final question, sir, Naveen sir, one final question. I think he's an young ophthalmologist. He's asking, in a benign intracranial hypertension proved with all investigations, I am giving Diamox for almost 4 months now. How long can I go on? That is the question.
And that's a very difficult question to answer. See, Diamox, maybe if your patient is not responding, then either the dose is not sufficient, and if the visual parameters are maintained. See, the only deciding factor is our clinical evaluation. If there is no signs of optic disc edema coming down, worsening of the vision, worsening of the visual field, then you have to escalate your treatment to the next level. If you're seeing the patient for 4 months, the disc edema is responding. If you have structurally proven by an OCT that the disc edema has come down, no worsening of visual field, probably just ask a patient to escalate. And if it is going to be a classical IIH, again, I'm coming for the flags, red flags. If it is going to be a female, overweight, reduce the weight, and then probably see whether the Diamox is getting the effect in that patient or not. But if it is the same, your patient is not an obese male patient, then you reconsider your diagnosis of IIH.
Great.
I would agree. I think there's some point in time when you're treating a patient with what you presume to be papilledema with steroids, and if you can document, I think it's important to do OCT in these cases with fundus photograph to document at least some reduction in the papilledema. Your treatment should be working at least partially. If you say there's no improvement at all and it's still looking exactly the same, one is you have to reevaluate your diagnosis. Are you dealing with a pseudopapilledema? I don't know. You check your ultrasound, see if there's a drusen hidden somewhere. But if you feel that's not there, I think this is the time where you escalate, like Dr. Ambika said. I think this is the point where maybe a lumbar puncture and measuring the CSF pressure becomes important to confirm what you're treating is correct or not.
Yeah. Yes, sir. I think with that, Manoj, any questions from your side, or else we'll go to Dr. Mahesh.
Okay,
so now,
we'll move on with Dr. Mahesh from Arvind Eye Hospital. This is an informal introduction to Dr. Mahesh, I would say. We all know of Dr. Nachia. She is the doyen of neuro-ophthalmology in India. But if for me personally, if I had to think of someone after Dr. Nachia in Arvind Eye Hospital for neuro-ophthalmology, that is the person who's before you right now. Thank you, Mahesh, for coming and joining us today. Mahesh is going to talk on the evaluation of pupils in neuro-ophthalmology. Go ahead, Mahesh.
Welcome, sir. All yours.
Share my screen. Are my slides visible?
Yes, it is.
Thank you, sir, for that introduction. First of all, I would like to thank the organizers of this conference for having invited me here, and it's a privilege and a pleasure to be here. And it's wonderful to be talking to the postgraduates and all the other practitioners. So the topic given to me is evaluation of pupils and its neuro-ophthalmic importance. But whenever the postgraduates come to our department of neuro-ophthalmology, I tell them neuro-ophthalmology is not a specialty, it's a basic ophthalmology. And there can be nothing more basic in neuro-ophthalmic examination than the pupillary evaluation, which will apply to all specialties in ophthalmology and all aspects of ophthalmology. So in evaluating the pupillary abnormalities, initially any abnormality we will go from the history. But history-wise, will any patient come to us saying that I have a pupillary abnormality? In our country, because of our dark iris, in general, they do not come to us saying that I have a larger pupil in one eye or a smaller pupil in one eye. So because of the dark iris, the anisocoria is not readily visible. So they might come to you with saying that I have got blurred vision in one eye, or I have difficulty in reading in one eye, or I have got photophobia in one eye. These are all the sort of symptoms which the patients will come to us, and we need to elicit the relevant history and the relevant findings. So history-wise, we need to go, if there is some sort of pupillary abnormality which we have deduced, history-wise, we need to ask whether there has been a history of trauma, because trauma, as we know, can cause a sphincter abnormality. Likewise, iatrogenic causes like a simple cataract surgery also can cause pupillary abnormality. Occupation-wise, any accidental installation of eye drops or any other exposure of any insecticides or like thing can cause pupillary abnormality, and drug histories like accidental mydriatic installation. Any past herpetic infections, viral infections can cause iris atrophy and cause pupillary abnormality, and even episodic migraine history is also important to know about any pupillary abnormality. The next thing is we'll come to the regular torchlight examination. But before that, we need to have a slit lamp examination to know what is abnormality going on. For example, in this eye, there is a festoon pupil with multiple posterior synechiae. And so the likely cause of pupillary abnormality is a past uveitis. Looking at the cornea, there is some amount of opacity, likely a past herpetic infection. Anterior chamber for any cells for ruling out any iritis, and any transillumination defects of the iris we need to rule out. And in this, it's a bilateral dilated pupil, and we can see its total loss of the lashes. So madrosis likely causes a past Hansen's uveitis causing a pupillary abnormality. So we need to correlate with the history as well as the general examination to know the likely cause of the pupillary abnormality. So now coming to the basics, how do you test the pupillary reaction to the light? So the first step is to dim the room illumination, reduce the ambient light. As the patient fixate at a distant target, we don't want accommodative pupillary reflexes getting missed as pupillary light reflexes. Shine the light from below and illuminate both the pupils uniformly first. For example, shine at the root of the nose first to know the size of the pupils, both eyes simultaneously seen. So always mark the size of the pupils first, then the shape of the pupils, then the reactions of the pupils. Note the size and the shape of the pupils. So we need to know the pupillary pathway to know why there is an equal pupillary reaction when we shine the light. So when we see here, when we put the light, there is a double decussation of the light fibers. First decussation occurs at the chiasm, and the next decussation occurs at the pretectal nucleus before splitting to the third nerve, subnivous third nerve, and then going to the pupillary parasympathetic pathways and going to the pupillary fibers. And that is the reason why we have this equal light reaction and sensual response to any pupillary light reflex. So we'll see with some case examples. We see a young woman coming to us with a defective left eye vision of 10 days duration. The visual acuity was 6.6. I'm sorry, this left eye had a relative upfront pupillary defect, and the left eye had a defective color vision. So these acute vision losses were already discussed by Dr. Ambika very well, and I'm just reinforcing these points and looking at the pupillary light reflexes. You can see ideally illuminated with a transillumination torch. You can see here there is a relative afferent pupillary defect. While doing this examination, make sure that you are illuminating both the pupils for equal time. For example, if you are illuminating this side for 3 or 5 seconds, illuminate this also for 5 seconds so that there is an equal light input in both the eyes. So it's obvious that this eye has got a relative afferent pupillary defect. We'll run it again. Show that this eye, the left eye, you can see here, it's coming here, has got it's dilating instead of constricting, and it has got a relative afferent pupillary defect. So this is another example of illustrating the relative afferent pupillary defect. You can see here, if you strictly shine the light to one eye only, doing the swinging flashlight test, and this is a total afferent pupillary defect, indicating a total transection of the optic nerve. So the likely vision in this eye will be a no light perception. Of course, RAPD can be graded from grade 1 to grade 4, and this is an absolute grade 4 afferent pupillary defect. And anything in between, anything before the absolute afferent pupillary defect will be grade 1, 2, and 3, which are relatively graded from mild to more severe forms. And grade 4 here is the most severe form of afferent pupillary defect. Does this mean that the lack of RAPD means the afferent system is normal? There is no RAPD, both the pupils are equally constricting to light. Does that mean the optic nerves are normal? I want the postgraduates to think about this. Can we easily call it as normal? The result is false. The reason here that is the term RAPD means it's a relative afferent pupillary defect. Relative means relative to the other eye. So there is an asymmetric damage to the visual pathway. So one eye may be normal, the other eye may be affected. RAPD on one side does not mean the other side is normal. It only means that the side exhibiting the RAPD here is worse than the other eye. So if both the optic nerves are symmetrically damaged here, then there is no RAPD. For example, if both eyes got 5/60 vision and both eyes got a partial optic atrophy, then one eye is not, and we'll assume that the fields are symmetrically affected and the optic nerves are symmetrically affected, and there will be no RAPD because there is no relative weakness of one pupil compared to the other. So no RAPD means no RAPD if the damage is symmetric, but both the pupils may be sluggishly reacting to light and maybe a sort of ill-sustained pupil, but we will not be able to demonstrate RAPD in a swinging flashlight test. So that is the way we have to interpret the RAPD. And the next point to be remembered is we need only one working pupil to demonstrate RAPD. We'll see this subsequently. What do you mean by working pupil? Which means if the other pupil is mid-dilated and fixed, then how do we demonstrate RAPD? We will see subsequently. So these are all the points we have to remember in case of RAPD. There are certain uncertain conditions which will demonstrate RAPD. For example, amblyopia may demonstrate a small degree, grade 1 RAPD maybe. Prolonged monocular occlusion, you suddenly release that eye will become super sensitive to light. And so the other eye may show a small relative afferent pupillary defect. Anisocoria, the larger pupil will become less sensitive to light because it has been constantly exposed to light. So the other pupil might exhibit a small, the larger pupil might exhibit a small RAPD. Will complete blood, hyphema, vitreous hemorrhage cause RAPD? There will be no RAPD in these conditions. Are optic nerve the only conditions, optic nerve dysfunctions causing RAPD? No. A large macular lesions, like a large chorioretinal scar, can demonstrate a small degree, maybe a grade 1 RAPD because of the loss of ganglion cells. So you should not think that RAPD is seen only in optic nerve lesions. A large macular lesions, a large retinal detachment can cause a relative afferent pupillary defect. The only difference between these two is a mild degree of optic neuritis or optic neuropathy may cause a large degree of relative afferent pupillary defect, whereas a large macular lesion will cause a small degree of relative afferent pupillary defect. Does cataract cause RAPD? This question will always be in the minds of a first year resident, first year PG, because cataract, the mature cataract is slow, totally occluding the eyeball, occluding the light pathway. Will it cause RAPD? The answer is there will be no RAPD. Why? Because a cataract, like a mature cataract, will cause total internal reflection. And in fact, it is said that it will cause total internal reflection and cause super sensitivity to light on that side, and the other eye may show a small relative afferent pupillary defect if carefully looked for. But don't look for a RAPD in a cataract in the other eye. The take-home point here is a mature cataract also will not show RAPD because of this reason, unless there is a coexistent pathology in the retina, a large retinal pathology, or an optic nerve pathology, either optic neuropathies, either due to glaucoma or due to any other conditions. So subjectively, we grade from grade 1 to grade 4 RAPD, like what we said. Objectively, we can grade it with what are called as a neutral density filters. These are basically photographic filters which vary from light filters to more advanced filters. How do we use this? We place these filters over the good eye. Remember, over the good eye. We are basically trying to make the good eye as bad as the affected eye. So if we place the good eye, a grade 0.3 log units filter over the good eye and see for RAPD in the other eye, if the RAPD disappears, it means that this RAPD is equal to a 0.3 log unit filter. However, if it does not disappear, the RAPD is still present, although it is milder in degree, then it means that we need to place more dense filters, for example, log 0.6 log units, or maybe a log 0.9 log units, meaning that this RAPD is a more severe condition. So this is a rough estimate, especially in case of research studies, to demonstrate, objectively demonstrate and document relative afferent pupillary defect. Remember, it is placed over the intact optic nerve. So far we have seen about afferent system pupils, mainly about relative afferent pupillary defect. Now we are coming to the next concept, which is an efferent pupillary defect, what I like to call. Now this is a 60-year-old gentleman coming to us with drooping of the left upper lid of 10 days duration. He also has cataract, and this visual acuity is corresponding to his cataract. And this was his ptosis, total ptosis, and he has got ocular movements restricted, consistent with the third nerve palsy. And this was his pupils. This was the same gentleman's pupil, which is dilated and fixed. We will see a video of this. It is not constricting to light at all. And when we put 1 drop of 0.2% pilocarpine, it readily constricts. We'll see why this happens. So this pupil is dilated because of absence of neurotransmitter due to a third nerve palsy. Neurotransmitter here is acetylcholine, and when we supply acetylcholine in the form of artificial acetylcholine like pilocarpine, it readily constricts. So this is a point which postgraduates have to remember to differentiate between a third nerve pupil and a pharmacologically dilated pupil. Because pharmacologically dilated pupil will not readily constrict to pilocarpine, 2% pilocarpine. So we'll see what an efferent pupillary defect is. So we are shining the light here in the right eye. Right eye is a dilated fixed pupil. When we shine the light here, this eye is not constricting. But you can see here, this eye is readily constricting. Now, when we shine the light here, this eye is again constricting and this eye is not constricting. This means that these people will not constrict for anything. It is resistant. It is relative afferent pupillary defect. But when we shown the light here, these people are constricting. This means that this side optic nerve was intact. This is what I meant by saying that only one working pupil is enough to determine RAPD. So when we shine the light here, this pupil constricted, meaning that this optic nerve was intact. And if this optic nerve was damaged in the right eye, this pupil would not have constricted. That was the corollary here. So any pupil involving third nerve palsy, we should rule out aneurysms and other compressive lesions in the brain. And we have seen here, this is a posterior communicating artery aneurysm. This is a third case, a 30-year-old male, again demonstrating a dilated fixed pupil. This is a semi-comatose patient, the bilateral dilated fixed pupil, and you can see an exotropia here, and then he had a third nerve palsy. Neuroimaging showed enlarging subarachnoid hemorrhage here, and it is constricting the third nerve against the brainstem, and this pupil is called as a Hutchinson's pupil. So subsequently, the pupil was evacuated by the neurosurgeon, and so he was regaining this ocular movements as well as the pupillary constrictions. So that is the reason why neurosurgeons will not allow you to dilate a pupil when you go and see a patient in the ICU, because they are critically dependent on the pupil dilatation or constriction to determine whether there is going to be a raised intracranial pressure. So that was about the efferent pupillary defect. So the next concept is a pupillary light near dissociation. So I want the PGs to think about this. Pupillary answer this question. Pupillary light near dissociation means, does the pupil react better to light than accommodative stimulus, or do both pupils react poorly to light, or a pupil reacts better to an accommodative stimulus than a light? So remember the Argyll Robertson pupil, which is classical example of pupillary light near dissociation, accommodation reflex present for AARP. So always accommodative reflex will be better than the light response in a pupillary light near dissociation. So examples of this is a young woman presenting to us with blurring of vision of 10 days duration. The visual acuity in the right eye was 6.9, improving with 0.5 to 6.6. And the right eye was unreactive to light and slow to converge. You can see here, for example, this was the right eye dilated pupil, and it is slowly and tonically converging to near reflex. And this was the video of this thing. You can see the vermiform contraction. There is a sectoral contraction of the pupil, sectoral contraction of the pupils. This is called as a vermiform contraction, and this is suggestive of a AD's pupil. AD's pupil due to likely a viral infection of the ciliary ganglion. And how do we detect this? We instill a very dilute pilocarpine, a 0.125%, It is not readily available in the market. So we need to dilute that 2% pilocarpine maybe with a 0.5 ml with 7 ml of artificial tear or 1 ml with 14 ml of artificial tear solution in a sterile bottle and wait for 30 minutes. Remember, you have to apply this in the good eye also to act as a control. So how does this act? This weak pilocarpine will make the AD's pupil constrict because of denervation supersensitivity. So this denervation supersensitivity will take about 7 days to 10 days to develop. So if you see a patient presenting to you acutely within 2 days, this test may be negative. So you call the patient again after 7 days, this test may become positive. So this is a caveat for this test. So clinically, you have to diagnose this. And AD's pupil is a postganglionic parasympathetic dysfunction. Remember, there should be no ophthalmoplegia because if you get a ophthalmoplegia, you have to suspect a third no palsy. And third no palsy is an emergency. We have to do a neuroimaging because we should not miss a aneurysm, which is potentially dangerous to the patient. If it ruptures, the patient will die. So carefully look for the ocular movements. There should be no ptosis. It's a mydriatic pupil. You may experience a segmental iris contraction. There should be a slow tonic constriction of the pupil and a slow tonic redilatation. And there will be a light near dissociation, meaning that accommodation reflex may be present slowly and light reflex may not be present. So that is about AD's pupil in bilateral light near dissociation. This is another instance of a bilateral pupillary light near dissociation with a bilateral eyelid retraction. What test you would do for this? Will you put 0.1 to 5% pilocarpine? Or will you do a syphilis serology or a magnetic resonance imaging? Each one of this has got a meaning. So when we think of CT scan of the orbit, we are thinking of a localized CT, localized orbital pathology. Remember, there is a bilateral eyelid retraction. So we would not think of this. Will you put 0.1% pilocarpine thinking of AD's pupil? It is bilateral and you will not get eyelid retraction in a AD's pupil. So will you do a syphilis serology thinking that it is a Argyll-Robertson pupil? You may or may not have it, but you may not get a bilateral eyelid retraction. And the best thing is to do a magnetic resonance imaging of the brain. So you get what is called as a vertical gaze palsy, lid retraction called as Colliers sign, and a convergence retraction nystagmus. Is classic of Parinot's dorsal midbrain syndrome, which is an example of a light near dissociation. And dorsal midbrain, there might be a tumor. So when you get these signs, a convergence retraction nystagmus, the vertical gaze palsy, always do an MRI of the brain to rule out a dorsal midbrain syndrome. Argyll-Robertson pupil also will have a light near dissociation. Unlike a Parinot syndrome, which will have a mid-dilated pupil, here it will be a myotic pupil. Rarely we see this condition nowadays, but you have to remember this as a differential diagnosis. Other conditions are syphilis, diabetes, and multiple sclerosis. So if it is a dilated pupil, think whether the anisocoria is more in the bright light. If it is more, the anisocoria becomes more in the bright light. You need to think that the involved eye is not constricting to light, which will happen in a third no palsy, AD's pupil. And light near dissociation conditions you have to think of AD's pupil, Argyll-Robertson pupil, Parinot's dorsal midbrain syndrome. So that is about concept number 3. We have finished a light near dissociation syndrome. Now we are going to the last concept in pupils. We have seen afferent pupillary defect, we have seen an efferent pupillary defect, and we have seen a light near dissociation. And now we are seeing the last concept, which is a dilatation sympathetic palsy or a dilatation lag, which is a smaller pupil. This video is not working. So just see here, this is a smaller pupil, smaller palpebral fissure. It was a smaller pupil than this, and there is a dilatation lag, meaning that it is a sympathetic palsy. Remember that sympathetics act to dilate our pupil, and whenever the sympathetics are affected, our pupils will not dilate in dim illumination. And this patient had a typical Anfos tumor in a sympathetic palsy. This is another example of a Horner's syndrome, sympathetic palsy. You see here there is a ptosis. Again, it's more obvious here. A smaller pupil and a normal size pupils. And this is a general examination of the patient. You can see here there is a wasting of the thenar and hypothenar muscles in the hand. How do we correlate these two? The right eye this and right hand here. Whenever we see this, we think of a brachial plexus problem. How is brachial plexus linked to our Horner's syndrome? Think of the cervical outflow. The cervical outflow, something is happening here. So in this patient, there is a syringomyelia, there is a descent of the cerebellar tonsils, and this caused syringomyelia, causing the CSF is herniated into the spinal cord space, and it has affected the cervical outflow, causing a brachial plexus lesion, causing the wasting of the muscles. And this is an example of a central Horner's. We will see what a central Horner's is subsequently. So in a sympathetic palsy, chest X-ray we can do, or more importantly, we need to do a CT of the chest, MRI of the brain. Unfortunately, the sympathetic pathways has got a very long pathway originating in the brain, going all the way into the chest and down the sympathetic plexus, and again going back to the brain, which means that we need to image the brain, we need to image the chest, so as not to miss the lesion. All these pharmacological theoretical tests are good to know about. We can always read about this, but unfortunately, we don't get all these compounds here. So practically, we don't use these pharmacological tests except for theoretical purpose. It's always better to do a complete neuroimaging of the brain as well as the chest and the neck to trace the entire pathway of the sympathetic plexus. So summarizing the anatomy, it originates in the hypothalamus and here comes down the intermediolateral gray column of the spinal cord. So you need to image this entire pathway, goes down along the apex of the lung. This is where the Pancoast tumor impacts to the superior cervical ganglia. So till here is a preganglionic, and from here the postganglionic fibers go and goes to the sympathetic muscles here, as well as the sympathetic pupils. So as pupils supplied by the sympathetic pathway. So pseudomotor fibers are also here, which helps us to identify whether it is a preganglionic or a postganglionic pathway. So imagine this is preganglionic till here, and from here it is a postganglionic pathway. So this is the reason why you have these sympathetics are supplying the Muller's muscle here, as well as the smooth muscles of the eyelids in the lower lid also. That is why you have a partial ptosis here, as well as a inverse ptosis of the lower lid, causing an apparent inophthalmos. It's not a true inophthalmos, as well as a dilatation lag because of the paralysis of the sympathetic plexus. So now anisocoria here is worse in the dark. What does it mean? In dark, the good pupil will dilate, whereas the affected pupil will not dilate. So anisocoria becomes worse in the dark. These are the other things. Till the preganglionic, you will have anhidrosis. Since the pseudomotor fibers separate at the superior cervical ganglia, anything postganglionic will not have anhidrosis, and you will have meiosis and ptosis. See, these are the common causes of sympathetic palsy. Preganglionic can have these causes: Wallenberg syndrome, Pancoast tumor. Postganglionic, idiopathic or a cluster headache. Either preganglionic and postganglionic, you can have a internal carotid artery dissection. Remember, as ophthalmologists, ICI dissection is a medical emergency. The patient will come to you with acute headache and a Horner's syndrome. They got acute severe headache with Horner's syndrome. It's a medical emergency. Think of an internal carotid artery dissection. So finally, to anisocoria summary, normal light reaction more in darkness. It is physiological or Horner's syndrome. The anisocoria is accentuated in darkness. If it is accentuated in bright light reaction, it means that it could be a TNOA palsy, a pharmacologically dilated pupil in one side, or a sphincter damage. Differential diagnosis: normal pupils in a comatose patient. Remember, it is not a structural cause, it is a metabolic cause. So in an ICF, you see a good briskly reacting pupils and the patient is coma, it's likely a metabolic cause and not a structural cause. So this slide will summarize the pupillary abnormalities. The last slide here. Imagine right side is the affected pupil in all the slides. Here, normal lighting, mydriatic installation, right side is affected. It is dilated. If you install in mydriatic, it will not change for anything. It will remain static. It will not dilate. It will not constrict. It will not respond to pilocarpine immediately. In an AD's pupil, normal lighting, it will dilate. bright illumination will remain dilated because it will not respond to light. Accommodation will slowly and tonically converge. It will react, and weak pilocarpine it will constrict. Whereas a normal people will not constrict in weak pilocarpine. The third nerve palsy will remain dilated for accommodation, for bright illumination, everything. It will respond to pilocarpine 2%. Of course, you'll have the other oculomotor abnormalities in response because you're supplying pilocarpine externally in the form of acetylcholine externally in the form of pilocarpine. And Horner's syndrome, right eye is a smaller pupil. It will not dilate in dim illumination, remain small, whereas the normal pupil will dilate. This is called as a dilatation lag in dim illumination. Thank you for your kind attention, and let's end the slide.
Very thorough, sir. Very thorough and very elaborate. I think, and also for even for the youngest of young, the first year PGs, I think very lucid and very clearly explained. Couple of interesting questions, sir. One question I think an young ophthalmologist is asking: is there any situation where you will ask the patient to come repeatedly 2 or 3 days and check the pupil and confirm before deciding on the pupillary reaction? Is there a situation?
Yeah. So many times we are confronted with this situation, whether it's a pharmacologically dilated pupil. One of the common situations which I have come across is they would have gone to an ophthalmologist 2-3 weeks back, but we do not know whether it was atropinized. So in that situation, we always need to call the patient again and whether it is a pharmacologically dilated pupil. And number 2 situation is if it is a third nerve palsy, partial third nerve palsy, pupil is reacting at that time. We do not know whether something is evolving in the background, whether something is slowly compressing the nerve. So in this situation also, we need to make sure that we call the patient again in 2 or 3 days and see again the pupils whether it is getting involved. The dictum is any partial third nerve palsy, even if the pupil is apparently reacting well, it has to be considered as a pupil involving third nerve palsy because we really do not know whether something is evolving. These are the 2 situations when I can think of we need to call back again.
I think to extend on Dr. Mahesh's point, even in the message is even in a third nerve palsy, which is a complete third nerve palsy with pupil sparing in a middle-aged person, which you would probably assume to be a diabetic third nerve palsy, say. We all know that these improve completely fine without any treatment over 3 months. But it's important to tell the patient that not to tell the patient that you're fine, come after 3 months. I think it's important to tell the patient you may be fine for now, but please meet me after 10 days or 1 week, 2 weeks, 3 weeks, mainly to make sure that the pupil is not getting involved. Because even if you have a complete third nerve palsy and after 10 days you find the pupil becoming anosogoric and sluggish, you have to change your diagnosis because it's not a diabetic third nerve palsy. That way.
Yeah.
So I think it's important for periodic reviews, even in a total third nerve palsy, to make sure that things are on the right track.
Yeah. And Magesh sir, somebody is asking you about aberrant innervation pupil reaction.
Yeah, occasionally we come across aberrant regenerations in a third nerve palsy, a traumatic third nerve palsy, where there is a structural damage. So for the postgraduates, we need to think when an aberrant regeneration occurs. Whenever there is a structural damage, physical damage, then the other neurons which are trying to help this nerve causes aberrant regeneration. So whenever there is a traumatic third nerve palsy or sometimes a tumor compressing a third nerve palsy, compressing the third nerve and causing a pupillary involvement, when they regenerate, it might potentially cause aberrant regeneration. And sometimes when the patient looks medially when they try to adduct, then the pupil might constrict. That is an example of aberrant regeneration. There is some mnemonic, there is some named this thing, I think, Zarnicki sign, or I remember Dr. Naveen Jekma's class.
Zarnicki sign, yes.
So that is one instance of aberrant regeneration of a third nerve palsy.
Yes, sir.
Aberrant regeneration of the pupillary involvement.
Pupillary.
I'm not able to think of anything else apart from this.
Yeah. One another, I think, is also in practicing ophthalmology. He's saying, I'm having a patient, a young boy with raised ICT because of CNS causes, and he's having nystagmus. I find it very difficult to record the pupil. Can you give me a clue? That is a question.
I would read the question as raised ICT with nystagmus to record the pupils. Is that correct?
Yeah,
sir?
he's saying probably I think he's meaning the nystagmus is making him difficult. He's just explaining the situation. We leave that. In a nystagmus case, pupil recording. That I think is what he's stressing on.
I don't have a definitive answer for that. I would also have a difficulty in looking at the pupils, and
All
I'd
of
like
us
to
would
get
have a difficulty with
other
it.
panelists. Other
Probably,
panelists can help me in this.
yeah.
I also have no good answer for that.
He is in fact asking us to help him with some clue. He's saying, I'm having a child, I'm having a young boy with raised ICT who is coming repeatedly for ocular examination by the pediatric neurologist. And with the nystagmus, I find it difficult to record the pupil. That is what he's saying. So he's asking for some clue in this situation, how to better handle pupillary evaluation. That's what he's asking.
I think at a very basic level, Mahesh, what you could probably record is, I think, is there any anisocoria, which I think is important.
Yeah.
It's probably, if depending on the speed of the nystagmus and I mean the frequency of the nystagmus, it's going to be very difficult to actually sit and do RAPD or a pupillary direct reflex and things like that. One won't be able to comment with any degree of definitiveness about that, and that's something that has to be accepted.
Yeah.
One more thing I can think of is maybe we can record those pupils and put it in a slow motion. There are
yes.
I think there are video programs for that, and
there
recording
is
all
a lot of infrared pupillography and with nystagmus, which can
or
be done.
even a normal cell phone camera also, good camera, we can record and play it in a slow motion, and probably what our mind cannot, brain cannot recognize, the instruments can recognize. Maybe I can think of that. I don't know.
I think with
I have a question.
I think, yeah.
Yes,
sir. Yes, sir.
Before I board the flight, Mahesh, it was really fantastic. I think it was a really fantastic masterclass, probably the best till so far, actually, I would say. And the first time I've seen Rohit Sharma, Virat Kohli, and Mahendra Singh Dhoni all playing for the same IPL team. The three of you. Really fantastic. I just want one tip from you, Mahesh. How do you examine the pupil on a bedside patient? In a bedside, how do you examine the pupil? And the patient is disoriented, and the patient is in the bedside, and you want to do a bit, because many times we are called to some ICUs to examine the pupils and give your opinion on that. Is there any tips and tricks for that?
Well, in a conscious patient, at least we can tell the patient we always need to prevent accommodation in a bedside patient. We need to, that is something which will get carried away, and we always need to bring the pupillary light reflexes from the lateral side. Otherwise, a bedside patient is prone to accommodate when we go near the patient, and that is something we have to prevent. That is one thing. In a semi-comatose or a semi-comatose patient, I do not have any specific clue for that. Maybe we just come from the temporal aspect and record the pupils. I would like the help of any panelist for any other specific
I would
point.
probably say a couple of more things. That in a bedside examination in a ward, I think it's important to have the ambient lights down, switch off the room lights, so that get the help of the staff nurse or someone to do that, so that your evaluation is more accurate. The other thing is the position of the eye in comatose patients may not be to your convenience. So you have to adapt the degree of illumination, the angle of illumination of the eyeball, depending on how the eyeball is located, because these patients may have a gaze palsy, their eyes may be rotated up or down or sideways. You have to make allowances for that. So I think these are important. I think recording the size is important, especially, which is something most ophthalmologists would ignore in the general situation, but becomes especially important in a comatose patient, is looking for the size of the pupil.
Yes, as we discussed, any increasing in the size is an alarming sign for the neurosurgeons, where they may have to evacuate any intracranial blood or anything.
Yeah. Exciting, sir, and very cerebral, very cerebral. And I think this masterclass is going to the next level. Shall we complete this panel discussion and go to the grand finale of today's masterclass? The course master himself, one who is loved by everybody who knows ophthalmology. He is as much an ophthalmologist as a gentleman, an officer and an ophthalmologist. We welcome Dr. Naveen Jayakumar to entertain us, because I think the person who can make some hard topics the most entertaining. In fact, that is one attribute we all wish every other student of yours wishes to emulate from you, sir, to make it entertaining, interesting, and to get into the patient, get into the students' psyche. These points is a very difficult task, and you do it with so much of flair. We welcome you to present this class on diplopia, because we are all puzzled with diplopia. I think you'll clear it up for us.
And Mohan, please don't miss your flight.
Flight will be waiting, sir.
If I miss the flight, the reason if I miss the flight, the reason is Naveen Jayakumar. Thanks, Naveen. It's a great honor to have you.
Thank you. So I hope you can all see my screen.
Yes.
Yeah.
Great. So good evening to all of you. The topic I'm going to discuss is seeing double, which is something not uncommon when a patient walks into your room with this particular complaint, or a friend who wants to get rid of a patient has referred it to you to spend more time with him. Now, seeing double can vary from something as slight as a slight blurring of, say, letters or an image on the screen, to a complete dissociation of the images, so that the patient is actually seeing two separate images altogether. So you have an entire range of what we call as double vision. But whatever the reason, whether it's a slight blur or it's a complete dissociation of images, the first question always remains the same. Is it monocular or is it binocular? What do I mean by these? So monocular diplopia refers to a patient complaining of double vision even when he is seeing monocularly. That is, if you close one eye, he says, maybe if I close the right eye, the left eye is seeing single, but if I close the left eye and see with my right eye, I am seeing double. Now, this double is actually originating from the right eye itself. Okay, so if there is a monocular diplopia, look for a reason within the eye. It could be as simple as an uncorrected refractive error, to cataracts or corneal disease, media opacities, and macular disease. Now, extremely rare, but not impossible, are bilateral visual cortex disorders. Now, these produce a diplopia, or sometimes even polyopia. You have 3, 4, 10, 20, 100 images also arising from each eye separately and in both eyes. Okay, so you have bilateral monocular diplopia or polyopia. These are very rare. Visual cortex disorders can produce this, but there will be other features of visual cortex disorders to allow you to make that particular diagnosis. But in general, if you have a patient with monocular diplopia, it's not a neuro-ophthalmic cause. Look within the eye for the problem. Now, one of the things that helps me, I thought I'll just share that with you, is something as simple as a pinhole and as simple as an artificial teardrop. Okay, so a pinhole would improve refractive error. Quite often, that slight visual blur which the patient complained at that eye would totally disappear. with a pinhole, and he'll say absolutely clear right now. And so you know that you're dealing either with a refractive error or a cataract. Of course, in macular disease, it may make things a little worse. The symptoms may worsen. Also, please don't forget that dry eye can also produce a slight bit of a diplopia. You put a drop of refresh tears or any lubricant that you want to, and you will be fine with it. Okay. Now, coming back to the second part, which is the neuro-ophthalmic part, which is binocular diplopia. That is to say, the patient is complaining of a doubling of images, but when each eye is being seen separately, for example, right eye closed, left eye open, seeing fine. Left eye closed, right eye open, seeing fine. Both eyes open, seeing double. Now that is binocular diplopia. Okay, so we will now see what do we need to consider for binocular diplopia. So what is there are some things that you need to go through first, which will help you a lot to identify the cause and possibly even the location of the problem. So one is, what is the nature of the diplopia, and a couple of other questions. Let's look at the first question. What is the nature of diplopia? Okay, so is the diplopia worse in the right gaze or in the left gaze? Is the diplopia worse when the patient is looking far away, divergence, or is it more when he's converging his eyes? Ask these questions. It is important. It's important because it not only, it probably will tell you which is the weak muscle. Okay. What about the image separation? Is it horizontal? If images are separated horizontally, you're dealing with a weakness of the medial or lateral rectus. Whereas if it is a vertical or a torsional separation, you're dealing with one of the vertical recti or one of the obliques. Okay. Is it horizontally? Is it crossed or uncrossed? Merely asking the patient, you close your right eye and tell me which image disappears. Okay. If you close the right eye and the right image disappears, it is an uncrossed diplopia, which is an esotropia. If it's a crossed diplopia, it's an exotropia. Most importantly, and finally, is it intermittent? You know, sometimes is it worse in the evenings, better in the mornings, worse in the mornings, better as the day progresses? Now, this is important because of that great mimicker of everything ocular motility connected, which is ocular myasthenia gravis. Okay. Let's move on to which muscles are weak. So we move on to ocular motility, ductions and versions, and this essentially helps you to identify which pattern is it falling under. Here, for example, you have a patient with a ptosis. The right eye is turned a little outwards. It is not adducting. Abduction seems to be good. What about elevation of the eye? Again, the right eye is not moving up, and neither is it moving down. Okay, so absence of adduction, elevation, and depression in the presence of ptosis, you all know what that is, and that happens to be myasthenia. That happens to be a third nerve palsy. What about vertical diplopia? That itself is a longish topic on its own, but and it's a little challenging as well, because the deviation of the eye in vertical diplopia is not very apparent, unlike a third nerve or a sixth nerve palsy. A fourth nerve palsy is a little difficult to diagnose. One of my professors, Dr. Lawton Smith, had a very, very simple thing to say about this. By and large, I use the word by and large, not all the time. By and large, if you have a patient complaining of vertical diplopia, just ask him which is the eye which has the lower image to it. Okay, so if the eye has a lower image, if the right eye's image is lower, just by closing each eye, you can determine that. If the right eye, the lower image belongs to the right eye, that means the right eye is turned up a little bit. Okay, that means that is the eye with a superior oblique palsy. This is a kind of a shortcut. You can even use a Maddox rod and determine the same thing. But this is a kind of a shortcut to tell you that that is the eye with the fourth nerve palsy. Fourth nerve palsies are, let me also say here that fourth nerve palsies are common, but they are not the only reason for vertical diplopia. Okay, but this broadly will help you. But if you want to go into detail, I would suggest you do the Parkes 3-step test. I'm going to show you the third part of the Parkes 3-step test here, which is the Bielkowski head tilt test. Now, this is a child with left hypertropia Okay. And the question to ask yourself is, in which head tilt is the left hypertropia worse? So you can see here, this is the right head tilt. You can see the position of the eye is more or less the same. But now what happens when the child turns his head to the left head tilt? See the left eye. You can completely see the upshoot of the left eye here, indicating that the left hypertropia is lesser on the right gaze and definitely gets a lot worse on the left gaze. And that tells you that this is a left fourth nerve palsy. Okay. Now, in a patient with a third nerve palsy, how do we evaluate the fourth nerve? This is something which is very commonly asked in examinations, and it also has a practical use. Let me tell you that. So the problem is, normally when we try and assess the fourth nerve, we adduct the eye and ask them to look downward. So it is basically depression in the adducted position of the eye. The problem is, in a third nerve palsy, the eye is unable to adduct. So how are we going to check for depression? You simply cannot. So what we do is we try and assess the other function of the superior oblique, which is intorsion. And intorsion is best seen when the eye is in the abducted, abducted position. Turn the eye outwards and ask the patient to look from up to down, from elevation to depression in the abducted position. Choose a landmark on the conjunctiva, such as maybe a conjunctival blood vessel, okay, and see whether the eye is turning inwards or not when the patient is depressing the eye in the abducted position. Okay, now I'm going to show you a situation. You may not see third nerve palsies every day, but what I'm sure you'll see every day is a peribulbar block in patients for cataract surgery. So I photographed that for you here. So this is a patient who blocked in the right eye. Now, when we block a patient, mostly it anesthetizes and immobilizes all the recti, but the superior oblique, because of its position, doesn't get anesthetized. So while adduction is absent, you will now see intorsion very, very clearly. So if you want to see what intorsion looks like, put a block and take a look. Here it goes. So when she's looking up, you see that rotation of the right eye when she looks down, from up to down. You can clearly see the eye rotating, and that will tell you that this superior oblique is working. Now, this is exactly the kind of movement you will see to tell you whether the fourth nerve is working in a third nerve palsy patient. Okay. Now coming to multiple cranial neuropathy, which I think is terribly important. Here is a patient who has little abducted eye, right eye, ptosis, zero adduction. Abduction seems to be working full. Depression is absent and elevation is absent. Okay. Now, the question is the superior oblique working? So what I did is turn the eye in the abducted position, ask the patient to look from up to down, elevation to depression, but no intorsion is happening in the right eye. Fourth nerve is involved. And last but not the least, I would like you to review that abduction movement. Okay, it's very mildly limited, but what is very apparent is the slow movement of the eye. You see how quickly the left eye jumps into the adducted position and how slowly the right eye turns outwards. Okay, I'll show it to you in slow motion. Look at the left eye, how quickly it jumps in and how slowly the right eye moves out. Here you go. And you can see the right eye still moving very, very slowly. This is a slow saccade, and this is due to a neurological involvement. The abducens nerve is affected. Okay. So this patient had a large right cavernous sinus space occupying lesion, which turned out to be a giant aneurysm of the internal carotid artery. Okay. So before we go on to lids, pupil, and orbit, so we saw a multiple cranial nerve palsies. Please don't forget two other cranial nerves which are involved apart from 3, 4, 6 is number 5 and number 7. So these two also need to be assessed. Let's move on to lids, pupil, and the orbit. Now, Mahesh has already spoken to you about this, so I won't spend too much time. Remember that anisocoria is unequal pupil size. Which is the abnormal pupil, you may ask? In general, what Professor Miller had said is, if there is a poor light reflex, it is an abnormal pupil. Even in a Horner syndrome pupil, you will find that pupil not the light reflex not working very, very well. It's difficult to see. Okay, so that may give you a general clue as to which is the abnormal pupil. So just do a simple light reflex. If you see a nice brisk reflex to a pupil, usually that is a normal pupil. Okay. What about the lid movement function? And Mahesh again spoke to you about the ptosis in third nerve palsy and the Horner syndrome. Here you can see this patient in the right eye. You can see that there is a mild ptosis here. And you can also see the position of the lower lid. Look at the position of the lower lid in the right eye here and in the left eye. In the left eye, you can see a little bit of scleral show here inferiorly, but you are not able to see that in the right eye. That is because the right lid has moved upwards. This is the upside down ptosis which Dr. Mahesh was talking about. And because of the ptosis on the top and this upside down ptosis below, this palpebral fissure is a little narrower, resulting in the apparent enophthalmos. Apart from that, look at the pupil size in the right eye. It's slightly smaller than the left pupil. Okay, so this is slightly myotic. Everything points to a Horner syndrome. Don't forget lid retraction. Thyroid disease can coexist with myasthenia. So if we see lid retraction, think of thyroid disease also. Now we have the situation of lid or pupil dyskinesias associated with certain directions of gaze, and this is due to misdirection of the nerve fibers usually between the medial rectus or the inferior rectus of muscles and either the levator or the sphincter, or maybe both. Now, one thing is important to remember is if you see a patient with aberrant regeneration, it is never, I repeat, never due to ischemic third nerve palsies. This can be due to trauma or space occupying lesion, and it is imperative to do a neuroimaging in these patients. Let's take a look at this video. So we have a third nerve palsy patient in the left eye. So we are trying, she's got a ptosis. So we've lifted up the lid and checking the eye movement. So you can see elevation, depression is restricted. Now, but when you're holding the lid like this, there is something that you can miss. Now, what is it that you miss? Let's take a look at the same eye movement from up to down and watch the left eyelid when she looks down. And you can see it jumping up there now. Now, this is typically on down gaze, the LPS is working. So there's a misdirection of fibers between inferior rectus and the levator, not only between these two muscles. Look what happens when she adducts the left eye. You can see the LPS working. So with the medial rectus and the LPS also, there is an aberrant regeneration. Dr. Mahesh spoke to you about the pupils. This is a patient who had trauma. You can see the normal pupil in the right eye and the dilated pupil in the left eye. Okay, so there is a clear anisocoria here. Now, looking at the pupil in the left eye in the abducted position, take a look at this same left eye pupil when the eye is adducting. You can clearly see a partial constriction happening, indicating that fibers which are going to the medial rectus have also gone partly to the sphincter pupillae. So when the patient is adducting the eye, some amount of pupil constriction happens by aberrant regeneration. Okay. Lastly, but not the least, couple of videos to show you about that particular great mimicker, which is myasthenia gravis. Let's take a look at quickly the lid signs of myasthenia gravis. So here is this patient asking him on sustained up gaze. Just look up for a couple of minutes, 2 minutes, and you can see the lid slowly descending down. And what these people have a tendency to do is because of the ptosis, they keep their chin higher and higher. You can see this patient by the position of his nose itself, you can see he's tilted his chin up to see clearly. The second is if I lift the right lid, the left one droops. Lift the left one and the right one droops. This is called a seesaw ptosis. And the last is the Cogan's lid twitch. On looking down, you can, and looking straight, you can see the little upshoot of the eyelid, and then it settles down to the normal position. If you have a patient with some peculiar eye movement problem and a ptosis, and you suspect it is myasthenia, you're in luck, because it's very, very easy to confirm myasthenia in these patients merely by the ice test. You needn't have an ice pack if you don't have it. Anything ice cold from the fridge will work. This video was taken by me in China, and this is a patient who had a myasthenia like lid movements, and you can see the pupil, the lid in the left eye ptosis. We only found an ice bottle in the lab, and you can see after a couple of minutes that ptosis has improved completely. Okay, so he seems to be happy with it as well, that the improvement in the ptosis. Of course, we had to tell him that that's only going to last for a few minutes. Okay, a couple of points about some odd situations that you might encounter. Suppose the patient is complaining of double vision, but the eye movements seem to be full. What do you do? So once again, just recheck for monocular diplopia. Look for subtle cranial nerve palsies. If it's a fourth nerve palsy, it may be difficult to pick up. Please consider variable or intermittent diplopia like myasthenia gravis in mind. And also, you may have concomitant squints of fovea which have been converted to tropias. More rarely, certain neuro-ophthalmic conditions like in bitemporal hemianopia may have this condition called the hemifield slide phenomenon, which produces diplopia. Skew deviations. Certain macular diseases, say with an epiretinal membrane, where the fovea is dragged to one side slightly, and that produces doubling because the image is falling in two separate places. Okay, the degree of the deviation would be equal in these patients, and there are certain ways to test it out. Functional is, of course, one thing, and my colleague Prem Subramaniam added these couple of other things: sagging eye syndrome, stable ocular myasthenia gravis with loss of fusion, and a condition called fixation switch diplopia, which you can read about later. But I think this is a broad list. I think what I listed out on the left side of the slide, I think most commonly would be what it is. So keep this in mind. I would be failing in my duty if I didn't put up any red flags as far as diplopia is concerned. So what are the dangerous diplopias? If you have pupil involved third nerve palsy, like Mahesh highlighted, it could be an aneurysm. What about painful ophthalmoplegia with orbital signs? Yes, it could be a Tolosa-Hunt syndrome. Dr. Ambika showed a patient with acute orbital condition with sarcoidosis. Keep that in mind. Diabetics, uncontrolled orbital mucor is a dreadful condition to have. Any patient with multiple cranial neuropathy deserves neuroimaging. These could be problems with orbit, cavernous sinus, or skull-based lesions. If there's a problem with more than one of these, if there is lid plus pupil, or if there's pupil plus eye movement issues, or there's a lid and an eye movement issue, I think these require further assessment, because ptosis with a small pupil could be Horner's. A ptosis with a larger pupil could be a third nerve palsy with aneurysm, or a Guillain-Barré syndrome, or a Miller-Fisher variant of the Guillain-Barré syndrome. Varial diplopia with weakness and fatigue, of course, myasthenia gravis. And don't forget that myasthenia gravis can be a serious risk to life, especially if the diaphragm is involved, respiratory issues, and a myasthenia crisis as well. And of course, last but not the least, any new onset headache, scalp tenderness, pain on chewing with diplopia, think of giant cell arteritis, think of aneurysms. These are the dangerous diplopias that really one should be very, very careful of. And with that little warning message, I conclude my talk. Thank you very much for your attention.
Wonderful, sir. Great, great. As usual, as usual. And the questions have also been like typed in. One question an young ophthalmologist is asking is recent diplopia, one day. So immediately, how do I relieve the diplopia to the patient? That is what he's asking.
Okay. I'm assuming it is a binocular diplopia.
Yeah.
And I think the quickest, see, you obviously have to assess, go through this whole process, which I just described, and find out why there is a diplopia in the first place. I think if between trying to find out the nature of the diplopia and its possible cause, I think those are more important than treating the diplopia at that point in time. But assuming you've gone through the process, you've looked at it and say maybe it's a third nerve palsy or whatever it is, and there's a diplopia, or a sixth nerve palsy and a diplopia. Well, the quickest way to manage binocular diplopia, I think, and the commonest which most of us do, is some kind of a partial occlusion. I use a 3M tape over one side, and it relieves the problem in most of the cases. If the diplopia over time, if the diplopia is constant, then you can consider prisms. Or if it's not improving at all, and if it's a large deviation, you may need to do surgeries. The other option, of course, is the Fresnel prism. Fresnel prisms, of course, you can, they're temporary, they stick on, you can keep changing them as the diplopia changes, but that is an expensive option amongst all these. Mahesh, Ambika, anything to add to that?
Yeah. One add-on question he's typing in is, will Dr. Naveen use Botox anywhere?
Okay, I'll come to that, but let me just finish with Mahesh and Ambika on the previous question.
One question which the patients ask us always is, whenever we give an occluder, which eye to cover. So whether it is
yes,
paralyzed eye or the normal eye, and what do we say for that? It's really difficult for the paralyzed eye to be focused with most of the time, but we need to use a paralyzed eye also. I want your thoughts, Dr. Ambika.
I mean, I would think, I think most of these patients hardly use this occlusion all the time. So I think the risk of amblyopia is less. But generally, if it's a very mild deviation, I prefer to keep the dominant eye open. I think most patients are comfortable with that. Even if the dominant eye, if it's the right eye, happens to be the one with the palsy, they seem to be more comfortable with that. But of course, if it is, say, it's a large sixth nerve palsy in your dominant eye, I think they would prefer to use the non-dominant eye, which is at least looking straight ahead. Ambika, you have any thoughts on this? How do you manage? I can't hear you. Again, we have a problem with Ambika's.
Yeah, madam has to unmute.
While Ambika gets back to us audibly, Mahesh, what about Botox? Do you?
Yeah, Botox is.
It is an option, yes.
It is an option, but we did a study where we found that there is no significant difference in mild to moderate cases, at least. Or, but still, it is an option. Maybe
it is theoretically on paper, it's an option, but in practice, let me say that I think all my patients are just very comfortable. I think many, even occlusion, many of them prefer to just leave it alone.
Yeah.
And use occlusion very, very rarely.
Yeah. At least in specific circumstances, when they're climbing a stair or something, when they're very bothered with the diplopia, they want
I think this is very, very important, Dr. Rajshekhar. You mentioned about climbing stairs, especially in patients with fourth nerve palsies. And going downstairs is when they're going to look down, and that's where the diplopia is going to be the worst. And there have been patients of mine who kind of fallen down and ended up with a more serious issue than the fourth nerve palsy. So I think it's very, very important to highlight to patients, close one eye and when you walk downstairs and hold on to something. Ambika, sorry, I can't hear you still.
Yes, yes, climbing down.
Mahesh, anything else? Any other questions?
One thing I just wanted to stress regarding the closing the paralyzed eye permanently is, does that increase the risk of, for example, if it's a sixth nerve palsy, does not using it at all, does it increase the risk of a medial rectus contraction? So that is
that is there. I mean, if you're not moving the eye at all, isn't it? But I assume that if a patient, even if that eye is closed, and if the patient is moving the other eye, I mean, by the usual physiological reflexes, the affected eye would also be moving in different directions and is not like immobilized in that sense. I think restrictive palsies are more a corollary of long-term palsy rather than just occlusion alone. That way.
In fact, you have taken me to the other question, which is also very interesting. Restrictive palsies have less diplopia. Is that a dictum? That is a question, sir. Restrictive palsies, do they always have less diplopia?
I don't think that's a hard and fast rule. But I will say something about restrictive palsies. But let me ask Mahesh that question. Do you feel restrictive palsies have less diplopia than neurological palsies?
Likely because of the, I have not seen that, but theoretically, maybe I would think that neurological palsies are more of.
I think they're more symptomatic.
Compensatory overactions might.
Am I audible now?
Yes, you are audible.
Yes,
finally.
madam.
Welcome
We
back.
are
Okay,
waiting
I
for
am
you
back.
for a very long time.
Voice of
Sorry.
Ambika. Yes, quickly, anything that you wanted to add
What
to the
questions should I
previous
answer
discussion?
now? I missed many, I guess.
We wanted to
You
ask
can
you, what do
slip
you
into
do
anything. Yeah.
to relieve diplopia in patients?
Immediately occlude.
Yes, occlude. Okay, that's
Which
it.
eye, madam?
What about Botox?
Whichever the eye the patient prefers. If the patient is, because depending on the vision, if it is a good eye, dominant, fixing the eye, that eye, if the patient prefers to be not occluded, I don't mind. Even if it is a non-peritic eye, the other eye I can occlude.
What about Botox? Do you use or not
I don't
use?
give Botox.
Okay, I think the jury, at least this jury of 3 people, is clear that none of us use Botox. I think, yeah. So it remains on paper. One thing I wanted to emphasize about restrictive palsies is, apart from we all do the force reduction test if there's a real doubt, but I think this slow saccadic speed that I showed in that multiple cranial nerve palsy, that is clearly a sign that the 6th nerve is affected in that eye. It is not a sign if you could say, is the eye limitation, abduction limitation happening because the medial rectus is thickened, as in thyroid disease, not allowing the eye to move outwards? Yes, possible. But in such a case, the speed of movement, the limitation may be there, but the speed of movement, even to that limited position, is absolutely fast as the opposite eye. So normal saccadic speed is what you would find in a restrictive palsy. A slow saccadic speed clearly indicates a neurological issue.
Yeah. And argumentatively, in a neurological palsy, muscle imbalance is going to be more. So there should be more diplopia. In a restrictive palsy, at least that muscle imbalance is not that very much. It is so less diplopia. Probably this questioner, the question person will like to go into those points and search the answers. And one another question which he is asking, I think he's a young student. It's a very nice question. He's saying, like, beyond this testing of extraocular muscle movements, I test corneal sensation, I test lid closure, I test Bell's phenomenon. Should I do anything more to test the other nerves that Dr. Naveen was stressing?
I think it's important. I think never forget the 5th and 7th. For example, if you had someone which presented like looking like a 3rd nerve palsy with pupil sparing, let's say there's a bit of ptosis and a bit of limited movements in different directions, etc. But if you did a concentrated squeezing of the eyes together, and then you find after some time you're actually able to gently open one eye, even though he's trying to squeeze it shut, or the eye is opening slightly and producing a scleral show, that will clearly tell you that's a weakness of the orbicularis muscle. Now, there is no neurological lesion inside the brain which can produce a 3rd nerve and a 7th nerve involvement. Okay, that combination is very, very odd. I mean, 3rd nerve is in the midbrain, 7th nerve is right down in the pontine area, nuclei. So you can't, it will be inconceivable to have a lesion that extensive and not produce anything else neurologically. So you see 3rd and 7th like this, you are dealing with myasthenia, no doubt. That way. Similarly, 5th nerve, corneal sensation, terribly important. If you see 3rd nerve plus weakened corneal sensation, you're automatically pointing to the orbital apex, superior orbital fissure, or cavernous sinus.
Yeah.
Sometimes we may have an isolated cranial nerve palsy, and yet we may have a superior orbital fissure lesion or a cavernous sinus lesion. It's not necessarily we need a multiple cranial nerve palsy to have an orbital apex lesion. So
Yes.
that you have to remember very much. And a past history of any viral infections like a hepatic lesion, you have to be very cautious in screening them for any orbital apex lesion.
Yeah.
Because we have seen a couple of inflammatory etiologies following a viral illness. And one question
Yes.
I am interested in asking both Dr. Mahesh and Dr. Naveen, like for your ADs patients, if they are very apprehensive about the loss of near vision, what is your treatment choice you give for? Do you prescribe pilocarpine eye drops or do you stick with the bifocals?
Actually, I stick with bifocals. I find most of my patients seem to be fairly comfortable with those if they want to use that. I have not found much success using pilocarpine, possibly because of the dilution issues. And if you use strong pilocarpine, then it's really produces blurred vision for distance and it makes the vision worse actually for them. So all things considered, I think a bifocal is the best option that way. I don't know. What do you do Mahesh, for these?
We give one bottle of pilocarpine to all patients, diluted. We are fortunate,
Diluted and give it. Okay.
diluted.
Okay.
We don't dilute it. Oralab, we are fortunate. Oralab gives us free of those samples.
That's nice.
So they dilute it under factory conditions.
You are sitting in an advantageous position.
Exactly.
And how long you will give them, Dr. Mahesh?
Yeah.
Actually, some of the patients come back repeatedly every
For
1 or 2
years, they do come
for years.
with the ADs. Yeah.
Yes. So every
I would
time-
like to ask you, Mahesh, with diluted pilocarpine, yes, the pupil size would get a little smaller. What is the effect on the ciliary muscle? Does it have an equally good effect for accommodation? Because that is the main complaint. Apart from the blur, I mean, mainly it's the blurred vision. You know, they have N8 or N10 near vision without correction, and they need about a plus 1.5 or something to see.
some patients have a few patients, like you said, not all patients are comfortable with it. I would say maybe 3 or 4, 2 or 3 patients out of 10 patients. If they're happy, they're very satisfied with it. And most other patients are not satisfied with it. And maybe we give them bifocals. But the patients who are happy with it are really happy, and their near vision also gets improved. And we really do not know why the difference between the individuals.
Because we have this difficulty when it is monocular. If it is a monocular ADs in young patients, it's really difficult to convince them with any management options because they are not the right ones for bifocals, because other eye having a very good near vision. And if they are not comfortable with the pilocarpine installation also, because I had a patient who is constantly, unhappy because of the previous advice of using a pilocarpine. His eyes are always red and he has headache, and that itself has caused a worsening of his poor near visual task. So that is the reason why I asked, because in young individuals, when they have a monocular ADs, it becomes really a difficult task to treat them.
True. True.
In fact, a final question, Dr. Naveen sir, I think he's the fellow, is asking, in internuclear ophthalmoplegias, is diplopia very different? Does it occur? Is it very common?
I'm not really, I don't
Interesting question.
know whether they have much of diplopia at all. I
Yeah.
assume that technically they should have. I do think they do complain of diplopia, which is why they come to us in the first place.
Yeah.
Beyond that, not much really. Mahesh,
I had a patient who was a young individual who was a known case of multiple sclerosis. Actually, we have been treating him for the relapses of optic neuritis, but suddenly he came back with an acute onset double vision, and he had a midbrain block, and that was the reason why he came with a sudden worsening of his status. So we had to treat him, but he responded very well. But the double vision was quite disturbing, and it was a very acute in onset, and his manifestation was an internuclear ophthalmoplegia.
Once again, I think, Rajshekhar, it depends upon the
etiology.
extent of the extent, not just the etiology. I think it depends on the extent of the deviation. I mean, you have internuclear, just like in any nerve palsies, even supranuclear palsies, you have variations of very mild deviation to a very large deviation. And the extent of diplopia, how much it's bothering the patient, depends on that. And generally, you will find that patients with very large deviations are reasonably more comfortable than the ones with very mild deviations. The ones where there's a very slight separation of images, that's what causes the most amount of annoyance for patients.
Yeah.
Yeah.
Sir, I have one
Great.
last question, sir.
Yes, please go ahead.
Yes.
Patient has bilateral advanced cataracts with sudden onset of isolated nerve palsy. So how long can we wait till the patient recovers completely or to take up for cataract surgery?
There is no, assuming it, let us say it is an, I assume it is, it's a diabetic, say a third nerve palsy or a sixth nerve palsy. I don't really see any issues in operating these patients. Theoretically, in the sense, especially if you say you're going to do it under topical or something like that, then it's fine. I usually use a peribulbar block when I'm operating, and because I'm using a peribulbar block, my preference, I prefer to wait a couple of months, 2-3 months, if it's not urgent, let the nerve palsy improve. And then, so, the patient is not having two problems, they're having only one problem left, at least, that is when they finish operating, there won't be any diplopia, at least for the patient.
Yeah.
I don't know, Mahesh, any thoughts on that?
Yeah, in general, we make the patients wait till the movements recover. Maybe 1 or 2 instances we have operated because they were
there's no contraindication in that sense, Dr. Manoj, but I think if you can wait, do it, you will have one less problem to deal with.
Maybe if it's an acute, we can wait it out for 6 to 8 weeks. If it's a chronic diplopia, or if you know that it's a thyroid disease or any chronic
that kind
disease,
of
which
patient, you can go ahead and
we can go ahead and perform.
Yeah.
Great, sir. I think I am missing Dr. Mohan Rajan here because he would have thanked you very profusely. But at least me, I'll make an attempt from on behalf of TNOA and on behalf of ARC TNOA. I think we thoroughly enjoyed this class. We strongly believe that this masterclass set the tab very high, and everybody who sat with us, we have crossed 2 hours and we are almost into 2 hours and 15 minutes. I think every minute was a thorough joy and enjoyment, and it was as much illuminating. I'll ask Dr. Manoj, my co-moderator, to give the formal vote of thanks.
Sir, excuse me, sir.
Yes,
hello.
Please go ahead. Yes.
Sir, I hear Dr. Logan, sir. Thank you so much for enlightening the diplopia, sir.
Great,
sir, I have one small question. So, as you said, in fourth nerve palsy, when the movements are almost normal, when patient is having diplopia, I have inquired here one local neurologist. He says there is a condition called cerebral polyopia, so that has to be ruled out. So what's your opinion on this?
Cerebral polyopia is what I had spoken about right at the beginning when I spoke on monocular diplopia, where the cerebral polyopia means it will be present even with one eye shut. Okay, because it's not arising from a misalignment between the two eyes. It is something your occipital cortex is producing multiple images. So first of all, if your patient is having only 2 images, it could be, you can say it maybe it is cerebral polyopia, but it is more likely to be a binocular diplopia due to misalignment. If you're saying 3 images and 4 images, it cannot be misalignment between the 2 eyes that way. So I think that there's no doubt about that differentiation. I think if you go through that stepwise asking of those questions, you can rule out cerebral polyopia right in first position itself.
When you want to reassess, suppose movements are normal and fundus everything's normal, so still patient comes to you, how often you ask the patient to review so that nerve palsy, if it at all, it can evolve?
Generally, nerve palsies, I review once in about, depends on the availability. If the patient is in town, I like to see them once in 2 to 3 weeks. Definitely in the beginning, definitely after a week to 10 days later, and then again after another week to 10 days later. Again, this is to make sure it's not a worsening condition, or a pupil is getting involved. That's mainly to see that. If they're otherwise stable, then I extend and keep watching them once a month for about 3 months or so.
Thank you so much, sir.
Great.
you.
Great.
Go ahead, Rajshekar. Go ahead.
Manoj,
Yes,
what a thanks.
yes.
Manoj, yes.
Yes. On behalf of TNOA and the ARC team, I thank our master today, Dr. Naveen Jayakumar sir, and the speakers, Dr. Mahesh sir and Dr. Ambika ma'am, for the wonderful session today on neuro-ophthalmology. And I also ask sorry from Dr. Naveen Jayakumar sir for troubling him for the last 3-4 months. Even though I've been out of country, he was answering my queries and accepting all the questions and coordinating well with our team and helping us do this 10th ARC TNOA PG Catalyst program. And I thank Dr. Mohan Rajan sir, President TNOA, and Dr. Rajshekar sir, the ARC Chairman, Dr. Loganathan, Treasurer, and other office bearers sitting with us for this session. And last but not the least, the team Milmet, which has been working on the background for us for all these 10 programs altogether, Mr. Raju and Mr. Deepak, and also from Mr. Akash for this wonderful opportunity this evening. So thank you very much, sir. Thank you, ma'am.
Great.
Thank you.
Thanks
Thank
a lot.
you all.
Thank you, sir.
Thanks a lot.
Thank
Naveen
you
sir,
all.
Ambika
Bye.
madam,
Thank you.
Dr. Mahesh. Thanks a lot.
Thank you, sir. Thank you.
Thank
Good
you.
night.
Bye.
Thank you, sir.
Thank you.
Thank you,
Thank
madam.
you.
Then we can close now.
Okay, thank you everyone. From here, I'm ending this meeting now. Thank you very much.
Thank you. Thanks a lot. Manoj, bye.
Thank you, sir.